Good evening. CAEP's Scientific Planning Committee has reviewed each presenter's conflict of interest submission, and none of our speakers have potential conflicts that have been identified, and no external support has been received for this webinar. Hello, wherever you are in the country. My name is Don Milady. I'm an emergency physician at Mount Sinai Hospital in Toronto and a member of the Schwartz-Reisman Emergency Medicine Institute. Along with Deb Eagles in Ottawa, I was the founding co-chair of the CAEP Geriatric Emergency Medicine Committee nearly 10 years ago. The next hour of rounds is going to focus on the care of older adults in Canada's emergency departments, and specifically focus on CAEP's new position statement on care of older patients in Canadian emergency departments. We hope this statement will improve the uniformity of care and quality of care that older people receive in Canadian hospitals. The Canadians know that there are some deficiencies at every level of the healthcare system, including in its capacity to address the needs of older adults. As an older Canadian going to an emergency department today, you can't really be sure that you are going to be treated by clinicians who have focused education about older people with the skills, knowledge, and attitudes to deliver the best care. But even more importantly, you can't be sure that you're receiving care in a system that was designed to meet your needs. Canada has an excellent healthcare system, yes, but it is definitely not a system that was designed with older people in mind at any place, and certainly not in emergency departments. It was designed more than 50 years ago at a time when there really were very few older Canadians around. But currently, there are one out of every 5 Canadians is over the age of 65, and by the end of this decade, it'll be 1 in 4. Our healthcare system in general has not caught up with that demographic reality, and we hope this CAEP statement will help emergency departments catch up. Our Geriatric Emergency Medicine Committee thought that CAEP needed a position statement on care of older people. We wanted CAEP to identify the most important issues to address and to provide practical solutions and strategies to do so. You will be able to see the learning objectives for this, but our goal for these rounds tonight is to introduce you to CAEP's position statement, ratified just last month by the board. So this is your statement. The full text is available by using a QR code, which you will see on many slides, and I believe it will be texted into the chat shortly. At the end of this hour, we hope you will be familiar with the position statement. And we think this is important because we hope that it is going to shape the standard of care in Canadian emergency departments. You'll have a chance to ask questions to all the presenters. And maybe most importantly, you'll see some practical examples of how emergency departments across the country are implementing these improvements. In a comment from Dr. Danielle Martin, my chair in my department in Toronto, and one of Canada's leading authorities on health policy, her comment was, "This statement reflects a future-oriented, compassionate vision for the discipline of emergency medicine. It's highly practical and therefore is likely to gain traction within the system." We hope you'll go away from these rounds with some inspiration to start making changes tomorrow. So before I finish and sign off, I'll give an outline of these rounds and what you can expect and introduce the speakers. First up will be Dr. Doug Sinclair, who's known to many of you. From Halifax, he is one of Canada's most experienced and respected emergency physicians and leaders and a lead author on this position statement. Not the lead author, one of the participants in this position statement. He'll give an overview of why this matters, and particularly bring the perspective of an emergency department manager, which he has been for many years, and of an executive of several large hospitals. Dr. Brittany Ellis from Saskatoon, who is the current chair of CAEP's Geriatric Emergency Medicine Committee, has led this whole project. She'll provide a detailed overview of the position statement. She will illustrate it with a video made in Sherbrooke in both official languages so that we can hear the voice of the most important stakeholders here, patients and their caregivers. Next, we'll have 3 pre-recorded talks from 3 geriatric ED leaders across the country describing practical examples of how they have improved their own emergency departments. The 3 are Dr. Osama Lubani, who is an emergency physician in Halifax, Ms. Nana Assomaning, who's a nurse practitioner at Mount Sinai Hospital in Toronto, with over a decade of experience as a geriatric emergency management nurse, and Dr. Kevin Wasco, who is an emergency physician in Swift Current, Saskatchewan. Finally, Dr. Audrienne Brousseau, who is an emergency physician from Sherbrooke, Quebec, where she developed and leads an accredited geriatric emergency department. She will provide some educational and practical resources that your ED can access. I do also want to mention Dr. Deb Eagles, who is not presenting tonight, but along with the 4 of us who are presenting alive, she played an essential role in the development and writing of this statement. And this product is also a shared project of every member of the Geriatric Emergency Medicine Committee. So with that, I'll turn the screen over to Dr. Doug Sinclair.
Thanks very much, Don, and welcome everyone. I was reflecting before this talk and realized that this is my 40th year of practice in emergency medicine, and I've been a leader, as Don said, in emergency departments, frontline doc, and hospital administrator. And I guess what I've noticed over the time is how much emergency medicine has changed. Back in the day, people were a lot younger. When they needed to be admitted, there were lots of hospital beds. Actually, people went to sleep at night. It was actually pretty quiet at night, and how things have changed. What we see now, of course, is with the elderly population is a huge amount of chronic disease. And the management of that chronic disease has become more and more complicated. And frankly, emergency departments are asked to do things they were never designed to do. I was delighted to be asked to participate in this work because I thought such a statement is so important at many levels. So important at the front line, and you'll hear lots of practical examples. Important for emergency chiefs and leaders because you folks are all in the front line, and we think it's be very helpful to have a position statement from our national organization that allows you to advocate for changes in your emergency department and in the system. And hospital administrators, as speaking as one, will really like this statement. And here's why. I've been a VP medicine in 3 different jurisdictions, and I can tell you, most of the time, doctors come in and they pound the desk and they say, people are going to die, everything's terrible, but they don't have any solutions. And frankly, it's such a delight when someone comes in with a solution, and you'll see lots of practical things tonight, even if it costs some money, it's such a relief. So this is what's so important. We have to, hospital administrators struggle with large number of elderly patients in the hospital, trying to move them to nursing homes, and that flow issue has been so dramatic and difficult. There's been enormous investments in primary care, and our primary care colleagues work extremely hard. But again, emergency physicians bear the brunt of trying to manage all kinds of problems that we frankly struggle with. And, we train in resuscitation, we train in fracture reduction, all kinds of acute issues, which is our kind of bread and butter. But more and more, the more of us that have been in this business, we realize that the older patient and their families, that is the vast majority of what we do. And I know some people get frustrated. They say that maybe this isn't what I signed up for. But I tell you, the nice thing about this statement is there's lots of practical strategy. It frankly puts some of the joy back in medicine because older adults and their families are so grateful for the work that we can do. I was really delighted to be asked to participate in this work because, as I said, I think it can be very helpful. One of the things that hospital administrators and leaders like is there some way that patients don't have to be admitted to the hospital, of course. And many things have been tried, and frankly, most of them don't really work very well. The nice thing about this statement, and again, it gives very practical statements for how do we assess the older patient, how do we assess their frailty, what are some of the things we can do in the emergency department to improve their care, and how can we discharge them safely? So those type of things really resonate with leaders everywhere. And the nice thing about this statement, it's very clear and succinct, and you'll see lots of practical examples as we go along. And, you know, I think during the time of COVID, when it's been so difficult the last 2 years, I think the really nice thing about this statement is and this work is really about the caring in medicine. Like Dawn, I'm a senior myself, so I look forward to this work, and I think a lot about my 97-year-old mother, and she's been in emergency for a few times, and I think mostly what folks need is a listening ear, some kind words, and again, some of the practical strategies, talking with families, bringing caregivers in, giving nutrition, helping with walking. These things don't sound dramatic, but make a huge change in the lives of our patients, can be very satisfying and helpful. The other thing I really like about this statement is we've designed it so that it works really at all levels. So it can work in a big hospital like Dawn is in downtown Toronto, but it can work in small community centers where resources are quite limited. And we specifically aim the statement at a variety of sources so that it can be used anywhere. And I know we have a physician later from a smaller city in Canada that can attest to that. So with this, I'll hand it over for much more content and videos of really exciting rest of the rounds. I'm going to hand it over to Brittany Ellis.
Thank you. Thanks, Doug. I'm happy to be here to speak about this, the CAEP position statement on care of older people in Canadian emergency departments. The CAEP Geriatric Committee recognizes that there's opportunity throughout each step of the ED journey to improve the care of older people, from triage to disposition to improve care, outcomes, and safety. This position statement endorsed by CAEP aims to provide support and guidance to EDs of all sizes. CAEP reinforces that the recommendations presented here will lead to improvements in quality of care and safety, not just for older patients, but for all ED users. The statement was developed through a rigorous process, including 2 large consultations. It has contributions from researchers, academics, health and social care providers, and leaders. We also importantly involved service users. The statement you'll see our executive summary will be published shortly in CGEM, where a link to the full position statement can be found. But for now, you can access the full-length position statement on the CAEP website or through the QR code, which is found on your screen now and throughout this presentation. The position statement itself used a Canadian perspective, the most up-to-date evidence and expert consensus to establish 8 recommendations. Each have practical examples of what implementation could look like. They're not meant to be prescriptive, however, as we recognize that EDs across the country not only vary in size, resources, and demographics, as we'll see here today, but also in current states of care. But no department is beyond improvement. I would now like to take time to familiarize you with each of the recommendations and share real examples of what's going on around the country and changes that you too could help create. The first recommendation acknowledges the reality that we only do or prioritize the things that are important to us. If EDs are going to change, they need to say explicitly that older people are their core users and that they are committed to improving their care. Mount Sinai Hospital in Toronto, where Dr. Mulady works, is a great example of this. They state that geriatrics is a key strategic priority in their emergency care. And by doing this, they have prioritized and allowed for all initiatives in care to reflect upon this important point, meaning that new initiatives and old are now older adult friendly. Like Mount Sinai, most hospitals and EDs have mission statements or sets of objectives that they strive to achieve. So talk to your departmental leaders, your hospital leaders, your colleagues. Doing this allows for and implores both a top-down and bottom-up approach to drive the change that is needed. Once older people are recognized as a priority, we can begin to ensure that all the changes are considered in this fashion. Recommendation 2 is about establishing processes for interdisciplinary assessment and care of older patients. In the ED, we work best as a team, whether it's with nurses, pharmacy, and poison control for that polypharm overdose, or trauma surgeons, anesthesia, and orthopedics in that trauma patient. This is what we do, and care of complex older patients should be no different. The adequate assessment and care of complex older patients are beyond the skill set of any single ED clinician and challenges the rapid assessment and stabilization model of typical ED care. Having access to interdisciplinary teams allows for more focused care, more information, and better, more personalized approach. Potential members of this team could include physiotherapists, occupational therapists, pharmacists, social workers, nurses, or more. And many of us already have these people in our EDs. We need to employ creative solutions, such as shared resources across departments or sites, or those which gained traction during the pandemic, such as virtual or remote assessments, to add more value. We need to focus on care coordination, mobility assessment, medications, and access to specialist services. You'll note, as Dr. Sinclair had stated, we added locally appropriate to our statement, as we realize that few EDs in Canada can have full-on geriatric teams. Similarly, though, few EDs can be trauma centers, but we put in place structures and processes that allow us to still do a good job to care for trauma patients. And we must do the same for older people. Improving readiness could be something as simple as creating a link to a physiotherapist in town who will see referrals directly from the ED, or finding telemedicine solutions by linking with larger centers who have more established resources. Later, we'll hear from a nurse with experience working as a geriatric emergency management nurse in Ontario, as well as from a colleague out east in Halifax who's working to establish an interdisciplinary team in his ED. In recommendation 3, the focus is on the importance of family members and caregivers. In this recommendation, we want to reinforce the core role that caregivers fill in the life of many older people, and that EDs must engage with them in a formal way. Carers are so much more than nice to have. Their presence can improve outcomes, reduce risk of things such as falls and delirium, and improve provider experience. They should be explicitly welcomed into the ED and included throughout the patient's stay, as they are part of the essential team. I would now like to introduce a short video by Dr. Adrienne Brousseau and her team from Sherbrooke University, highlighting this very important recommendation, as well as the aspects of interdisciplinary care from recommendation 2.
Ma mère, elle était pratiquement plus capable de marcher. C'est une dame qui aimait, très active, qui aimait marcher, mais elle était très étourdie. Ses jambes étaient faibles, elle perdait ses forces. Par-dessus ça aussi, c'est une femme qui est anxieuse, donc se sentant pas bien, son degré d'anxiété a pris de l'ampleur, jusqu'au jour, un matin, où elle m'a dit « c'est comme si c'est tout en train de se figer en dedans de moi ». Dans un très court laps de temps, il a été décidé que maman devait être vue, prise en charge par l'urgence de l'hôpital. Quand on est arrivé au préposé à l'accueil, l'expérience n'a vraiment pas été favorable. On demande à ma mère d'expliquer en 2 mots pourquoi elle est là. Elle est prise au dépourvu, elle veut dire les choses, les mots ne sortent pas. Les seuls petits mots qu'elle dit, c'est pas ce que le préposé veut entendre. Puis elle entend, se fait dire « Madame, répondez à ma question ». À ce moment-là, maman s'est reculée, puis elle tremblait. La porte d'entrée est d'autant plus critique parce que ça donne le ton pour la suite des soins, pour la suite de l'accompagnement qui va se faire au niveau, dans le milieu hospitalier à l'urgence. Il y a une infirmière qui est arrivée pour prendre maman, puis l'amener à l'urgence à l'arrière. Une dame d'exception. L'infirmière me rappelait pour dire votre maman a besoin de vous à ses côtés. Ma mère était complètement dépourvue, il n'y avait rien à faire. J'ai senti qu'on me permettait de faire équipe avec ma maman et de faire équipe avec l'équipe de l'urgence. On demandait des questions à maman, on se tournait aussi vers moi pour me demander aussi est-ce qu'on oublie quelque chose, est-ce que vous aimeriez ajouter quelque chose. En aucun temps on s'est senti brusqué. On a eu la visite de l'infirmière en gériatrie et elle s'est assise devant maman pour lui parler. Puis elle a été patiente pour répéter les questions sous différentes formes, puis pour finalement arriver à une question tellement simple, mais tellement significative. Madame Raymond, pourquoi vous êtes ici? Qu'est-ce que vous vous attendez de nous? Et là, ma mère, je la revois encore, elle s'est redressée sur sa chaise. Elle a dit, je veux remarcher. Dans le fond, son message, c'est, je veux mon autonomie. Cette intervention-là de l'infirmière, tant qu'à moi, c'était la porte d'entrée pour les soins et l'encadrement qui a suivi. Quand on a eu la visite, je dirais, de gens plus spécialisés côté gériatrie, je trouve que la communication et la compassion est à un autre niveau. Ce que j'ai à dire, c'est les remercier parce que sans cette prise en charge-là de leur part, puis ils sont allés avec, tu sais, malgré que ça courait partout, malgré qu'il y en avait jusque-là, je suis convaincue, ils ont pris le temps. Et ça a fait la différence.
Thank you. In recommendation 4, we shift focus to the prioritization of training and education of ED staff in care of older people. We recognize that emergency physicians have long received limited, focused geriatric education during training, and based on recent Canadian evidence, continue to lack confidence in their skill sets. Therefore, educational needs should be assessed and addressed at all levels of clinical training, from those late in career through to residency. Educational interventions should be interprofessional, focus on identified learner needs of core geriatric topics, and be varied to allow greatest attendance and experience. This perhaps sounds a bit like blue sky thinking, but it could include didactic, in-person, or virtual lessons, such as those available for free on geriem.com. And we're not suggesting you start something brand new, as geriatric skills can be integrated into things many are already doing, such as simulation and departmental rounds. Our committee is focused on ensuring educational opportunities exist and have worked to establish a strong presence of GERI-EM topics at national and regional conferences, such as the upcoming CAEP 2022 conference, SASC-EM and Sherbert conferences, as well as our upcoming CPD course presented through CAEP. Information on all of these, as well as joining, can be found on our committee webpage via the CAEP website. Recommendation 5 is about ensuring good care for common geriatric presentations. In the ED, we use all sorts of tools to help decrease cognitive load, improve flow, and enhance patient outcomes. We use tools to ensure certain disease entities are not missed. For example, most EDs have a pathway that patients presenting with chest pain will undergo a rapid ECG, often even prior to physician assessment. Similarly, there are many tools that we can employ to enhance the care and outcomes for older patients. For example, a delirium pathway, where tools are used to screen for and diagnose delirium, and management pathways can ensure that best practice is practiced, such as the avoidance of pharmacologic interventions unless absolutely necessary. Other examples include screening for frailty, altered trauma team activation, or falls pathways. And standard approaches do not just mean clinical pathways. There are vast improvements that can be made in EDs through enhanced attention to what are basic, even essential care needs, including hydration and nutrition, orientation, sensory optimization, and mobility. As a minimum standard, EDs should be safe and responsive to the needs of older patients, particularly those with cognitive and mobility impairment. Making efforts to accommodate the basic needs of older people and their caregivers through simple enhancements of the environment and equipment can improve the quality of care as well as the experience of all patients, caregivers, and providers. Major departmental changes can be achieved during times of move or redesign, but even small changes in accordance with age and ability-friendly design can positively impact care. For example, ensuring the availability of non-slip socks or raised toilet seats are simple changes that can enhance independence and safety of older patients, as well as potentially decrease demands on providers. Coming up, Dr. Wasco will share how his rural ED in Saskatchewan has made some positive changes through access to mobility equipment. And Dr. Alice Gray in Toronto, who is employing simulation and design thinking framework to improve end user experience for older people, also demonstrates this important point. Emergency departments should ensure high quality transitions of care. Transitions including from their home environment to the ED and back again, or upon admission, transfer, or wherever they are distant. While this may sound basic, I assure you it's anything but, and there are oodles of opportunity for improvement. For example, many, if not all of you, will have an easy pathway to get in touch with internal medicine when a patient requires admission. But how easy is it for internal medicine to get back in touch with you if they require clarification? Alternatively, how easy is it for you to get a hold of a patient's family physician in a timely fashion? How do you notify a specialist physician regarding an ED patient's visit? What do you do when you discharge an older person from the emergency department? What do you give them? Written, large font instructions? I'm guessing for most of you not. The ED is an important interface between all sites and people and needs to ensure that there is an excellent transition of care between it and all of them to provide safe, continuous, and coherent care. The final recommendation is about information, having the information you need to direct and monitor change. Now your eyes may be glazing over and you thinking this is pretty basic and boring stuff, but it's what you, your administrators, and managers need in order to support change. Do you even know how many of your patients are over 65? Most Gestalty answers will say somewhere between 40, 50, 60%. The reality is it's usually about 12 to 20. Do you know how many older patients are admitted in your ED? In some urban areas, there's up to a twofold difference in hospitals just blocks apart between their admission rates for older people. Wouldn't it be powerful to have the information to help stimulate adding resources to assess and address this discrepancy? Collecting data on attendance rates, admission rates, as well as things such as delirium screening, falls in the ED, and medication reviews are just a few examples of useful information you could collect to help create change. Quality indicators can be used to identify areas of success and areas for improvement, to communicate needs and accomplishment to hospital administrators, and to guide future initiatives. Check out our full-length position statement for many more specific ideas and examples of just what you can look for. These 8 recommendations were determined by national experts through a consultative process with an aim to guide change to emergency care for older people across the country. They are not prescriptive nor comprehensive, but represent a starting point for you to consider and to commit to change. There is so much more in the document, including practical examples, and we hope you can use the position statement to initiate change. Try establishing a group of interest amongst your peers and pull 1 or 2 SMART objectives to get started. In order to develop locally appropriate solutions and change, you may need to get creative, to think outside the box, to take small steps to gather even larger momentum. And we have a committee of nearly 50 members from across the country who are happy to help. So please don't hesitate to reach out. Now that you've heard about the recommendations, I'm going to hand over to my colleagues from across the country doing just these types of things. They're making real-life changes to improve care of older people where they are. To start us off, Dr. Osama Lubani, a critical care and emergency physician from Halifax, Nova Scotia.
Hi, my name is Osama Lubani. I'm an Emerge doc in Halifax. I'm really excited to be speaking at the rounds today. Thanks very much for taking the time to join. In the next 5 minutes or so, I'm hoping to talk a bit about the Halifax experience with implementing a multidisciplinary team to improve the care for older adults in the Emerge, what we've called STEM, or Senior STEAM in Emergency Medicine. And in particular, I'm hoping to talk a bit about what prompted us to start this, how we went about building the team, and what the implementation looked like. So to start, the impetus, at least for me, for getting involved with care of older adults in the Emerge was my frustration at the present state of things. I remember a case in particular that pushed me to get involved. It was a long weekend. I was handed over a patient who had been there for 3 days. And basically in the middle of the night, I was asked to do a competency assessment on this patient that I knew nothing about. So here it was late at night of a long weekend, and I was just handed this huge messy chart. And at that point, I just knew that we've got to do something about this, that there has to be a better way. So I started off by talking with other people, sharing my experience and seeing if other docs had had a similar experience. And lo and behold, every single emerged doc that I spoke with had had a similar experience. Some had even had worse experiences than I had. And bar none, every single emerged doc completely agreed that there had to be a better way to do things. And so what I took away from that, from my conversations with people, was that care of older adults was something on people's minds and they were ready to make a change. And when I saw that, I knew that now would be a good time to bring in a new initiative to address this. So once I figured out that our department was ready, the next step really was to build a solution. And if we wanted to build a solution, we needed to put a team together. And because care of the elderly involves a multidisciplinary approach, we put together a team of people from across the discipline. So we brought together people who were physicians, nurses, pharmacists, social workers, physiotherapists, and administration. We got everybody together so they could have a look from their different perspectives to see how we could approach this. And the question we asked is, what can we do to improve the care of older adults in our emergency department? And when we looked at this, we really looked at two main sources to answer this question. We looked at the literature, and there was lots of published experience, but we also looked at past experiences in our department and what had been tried before, what had worked, what hadn't worked. And we really took a good amount of time to look at what didn't work in the past so that we knew what we had to look for. And when we looked at our past experience, we knew that if we wanted to be successful, we had to follow a couple of key rules. So first of all, whatever we did had to be simple. It had to work within available resources. We had to have buy-in of stakeholders, and we had to have administrative support. And so as we went through, we made sure that we really focused on those things. So with all of that, we developed a workflow for what we wanted to do. And when we built the workflow, we really tried to make it very specific. We tried to say, where will things happen? Who will be involved? How long will it take? What would they have to do? And every step along the way, we kept asking, how could we make this simple? How could we make it more simple? And what are the downsides? So once we had our plan all set, we took it to leadership. We knew in advance the things that leadership had as a priority. So they prioritized overcrowding. So we tried to focus that on their priorities. We showed them how this would benefit overcrowding. We took a look at length of stay, bed management, all those kind of things. And we really focused on how this would improve those things. Now, thankfully, leadership was really receptive and gave us a green light, but we knew that if we were going to be successful, we had to have buy-in from the frontline people who are actually going to use whatever we're going to do. So before we got started, we spent a lot of time speaking with the frontline workers. We presented at rounds, at education days. We sent emails. We sent everybody, docs, nurses, pharmacists, social work. We sent everybody copies of the workflow so that they could see it, have an input, and let us know what they thought about it. And we got tremendously good input from people. There was lots of feedback that we used to fix things. And this was really important. Once we got people's input, we were able to get started. And the fact that we got people's input before was important because once we started, it wasn't new to anybody. Everybody had already seen it, they'd given their input, and they already felt a little bit of ownership of this because everybody had sort of told us what they wanted. And when we got started, we made sure to start small so that we could learn from any issues that came up and sort of build on top of that. So for example, we started just with doing a delirium assessment. Then once we did that, then we added medication reviews by pharmacy, then mobility assessment, then readiness for home. And hopefully with time, we'll be able to add more and more and more so that we can make it as efficient and improve care as much as possible. So, we haven't been doing this for very long now. It's been a couple of months at this point in time, but the lessons that we've learned so far is it's important to have a clear vision. Once you're making the plan, it's important to make an airtight plan where you can think of every step along the way what's going to happen. once you have a plan, you have to put it in the hands of people that are actually going to use it. You never know what sort of feedback you're going to get, how you need to change it. You got to be ready to change once people see it, and also start small and build on the initial success. So thanks for that. That's the Halifax experience. Now I'm going to hand you over to Nana Asamaning in Toronto to hear about the geriatric emergency management nurse role.
Hello, my name is Nana Asamaning, as you just heard. I was a geriatric emergency management nurse for nearly 10 years at Mount Sinai Hospital. And here in Ontario, many emergency departments have geriatric emergency management nurses. And what the role entails is what I would call the Jack and Jill of geriatric care. In the emergency department, we screen, assess, support, and help patients to navigate through the emergency department experience. There are often many unanswered questions in terms of the patient's care needs and, quite frankly, what to do next with the patient. And that's when the geriatric nurse comes into play. We have the time, resources, and expertise to sit with patients, hear their stories, collaborate with both the patient and their care providers, and build a plan to support them and their needs as they move through the emergency department. We also work collaboratively with our community support services, our occupational health and physiotherapists, our social workers, and anybody else who can help us to build a plan for the patient. So for example, not too long ago, we had a patient come into the emergency department that appeared confused with no physical findings. The team was quite dumbfounded as to what to do with this older woman who was claiming that her care provider had sort of disappeared. Most of us thought that she had quite a bit of cognitive impairment. And to be fair, she did. As the GEM nurse, I sat down with her, and in speaking with her, I got a name. And with that name, I called her superintendent, her pharmacist, and anyone who would listen. And by the end of it, we found out that she really did have a care provider who was providing her with quite informal supports in the community. That care provider had just had a massive heart attack that morning. And so with the support of our community care team, our physiotherapists, our occupational therapists, her superintendent, her pharmacist, we were able to build a plan to disposition this woman back to her home. If a GEM nurse and the GEM role had not existed, this is a woman who unfortunately might have been admitted to the hospital with cognitive impairment, failure to thrive, etc. But it was the whole team coming together to build a plan for her, and quite frankly, having the time to do so, that got her to the right place at the right time. And so that's in a nutshell what a GEM nurse does in the day-to-day. Broader, the GEM nurse definitely embeds themselves both in the emerge department and in the organization to make geriatrics a priority. So we always suggest and support that GEM nurses are not just consultants, but they're part of the emergency department. They're not just an add-on to your care, but they are a part of the organization and just one of the many building blocks to building out a geriatric strategy. So GEM nurses aren't just vital to the emergency department, but they lend a geriatric lens to organization-wide geriatric and otherwise initiatives. They become the eyes and ears of the geriatric population to ensure that their voices are heard and that their needs are considered when building out policies and procedures. But their core work in the emergency department informs this, which is why, in terms of advice to give to those with new GEM nurses, is to ensure that you embed this person both in the organization as well in the emergency department. And this person doesn't have to have all the answers. So start small. You don't have to have it all figured out before you hit the ground running. So now I hope that gave you a better idea of the GEM nurse role. And now I'll hand you over to Kevin Wasco in Swift Current, Saskatchewan, to hear about their experience in smaller rural hospitals.
Hello, my name is Kevin Wasco, and I work as an emergency physician in Swift Current, Saskatchewan. I'm going to share 3 easy and practical ways that an ED of any size can make the environment more senior friendly. Number one, universal screening. Using an established screening tool, we implemented universal screening for seniors that prompts an assessment in the community for seniors living at risk. Number two, mobility aids. Seniors often come to the ED via ambulance without their mobility aids. We invested in a cane and a four-wheel walker to ensure that seniors can be safely ambulated in the emergency department. Number three, personal sound amplifier. Many seniors have hearing impairment. We invested in a personal sound amplifier device for use in the emergency department for those that are hard of hearing. As you can see, it doesn't need to be complex to make an environment more senior friendly. It needs to just be easy things that we can put in place that can help seniors every day. Thank you.
Good evening, everybody. So I'm very happy to talk to you about useful and practical resources that are going to help you in your geriatric emergency medicine journey. This is not an exhaustive list, so if you know any other tools, please send us your ideas and we'll add them to our list. First, you may already know the famous e-modules geriem.com. It's 6 practical topics. It's discussed. It's very targeted for emergency physicians. It is free. It gives you CME credit, and it's very interactive, so I'm sure you'll like it. If you want more, please take a look at the Geriatric Emergency Department Collaborative. This is an American group, and they're developing great online clinical curriculums. So I highly recommend that you go take a look. You'll find something very interesting. And they do webinars every month, and they interview experts in their field. So it's very up-to-date information as well. If you are a podcast person, I suggest that you listen to the GEM podcast. It's done by Dr. Christina Chenby. She's a former geriatric emergency medicine fellow, and she's also interviewing experts in their field about specific topics in geriatrics, such as UTIs or head trauma, and it's always it's incredible stuff. You may already know the emergency medicine cases, and last summer they published a great podcast about geriatric trauma, part 1 and part 2, and I highly suggest that you listen to those 2 podcasts because I learned a lot of interesting stuff in there. If you are more of a evidence-based medicine person, if you want something more close to research, I recommend that you read the Acute Geriatric series. So if you click on that, you'll be directed on their website. And so far, they developed 13 articles, and it's done by great researchers all around the world, and it's very updated information about frailty, falls, delirium, etc. And if you are more of a research person yourself, there are various groups in Canada, but there's also this GEAR group who's doing more targeted research in geriatric emergency medicine. So if you like having something in your hand, I recommend those 3 books. So the Geriatric Emergency Medicine Principles and Practice. I really like this book because it's small chapters, it's very basic stuff. So I often will send my resident to read 1 or 2 chapters in there, and it's always, it covers the basics, so it's good. The middle one, it's also a geriatric emergency medicine book done more with a European approach, but it's also great knowledge. And the last one, the Geriatric Emergencies, it's written, you can see Peter Rosen and Anal Matthew. So it's a very, very thorough book, a different kind, a discussion-based review, but it's very fun to read as well. So if you want something to convince your administration, you now know the CAEP Geriatric Emergency Medicine Position Statement. So I put back the QR code if you didn't have time to scan it before. And even though they are almost 10 years old, the Geriatric Emergency Department department guidelines are still up to date au coup du jour. So I recommend that you take a look at what's in there, and there's also important information to help you make your case. If you're ready to make change, or if you want something higher level, if you want to spice your geriatric emergency medicine journey, go see the geriatric emergency department accreditation. So it gives you a worksheet with criteria and objectives, and also an attainable goal. So it will motivate your committee or your work group. Your administration will love it, will love the sparkling aspect of getting an accreditation, and it's also a quality assurance in the eyes of your patients as well. Oh, sorry about that. And lastly, if you want insider tips, if you want great implementation advice, if you want convincing argument, I strongly suggest this freshly out from the oven book. And you'll notice that one of the authors is Dr. Don Melady, and also John Schumacher. And this book is very interesting, very practical. So everything there is to know to create your geriatric emergency department is in there. And today you'll have even a 20% discount. So use the code. Finally, if you want to learn more from experts in the GEM field, I know there's a very few space left in our April 28th course. So 4 hours of great practical stuff. You can register with the QR code that I just put up. Finally, I always end with this message. You can have all the books, listen to all the podcasts in the world, but the best resources is you. If you want to make change in your geriatric, in your emergency department, you need someone to do that, and that someone may be you. So, merci beaucoup.
Thanks very much, Audrey, for that summary, and to everybody else who participated. Can I ask everyone to come on to the screen? I've been following some of the activity in the chat, and I'm getting other things in as well. I think I put into the chat when Nana was talking that those of us who work in Ontario have become accustomed to what a great resource geriatric emergency management nurses are. And this isn't just in the rare hospital. They are widely spread around all Ontario hospitals, which are larger than generally sort of 35,000 visits a year. So not very small rural hospitals, but large hospitals. So, and I think we're kind of surprised that the model hasn't spread to other places. One of the reasons people talk about is, well, what does it cost? How can we afford to do this? Nana, you ran the program at our place for years. What do you say to people who are concerned about the cost of starting a geriatric emergency management program?
I say that I think something like the GEM program may have an upstream cost, so to speak, but has lots of downstream cost savings in the form of avoided emergency, inpatient admissions specifically. We also appreciate that with the acuity of our emergency departments, that preventing admissions is a key factor in reducing what's the word I'm looking for? Reducing the volume in the emergency department.
Crowding
because we know
the word.
Crowding is the word. Because certainly we know that full inpatient beds is what leads to that crowding. And so costs are realized both in the emergency department, but also in the inpatient world, with a decrease in admissions for patients who, when admitted, also tend to stay much longer because of the work of supporting them back to the community. So if you can put up that upfront costs, the organization can look to realize a lot of downstream cost savings and downstream impact.
There's a comment in the chat, Nana. So from somebody whose gem nurse was cut, I can't imagine the wisdom of doing that. But the question is, what argument would you make to the management in that hospital that role is paying for itself?
Certainly, we know anecdotally that gem nurses in a week can look to result in 3 to 5 avoided admissions per week. But there is actually data that has come out in a recent research article, and I think Don can put that down in the chat if able, that demonstrates this cost savings. And so that article looked at about 25,000 emergency visits, half of them with a gem nurse or a social worker and half not. And those seen by the gem nurse had a $3,000 decreased health system costs over the month that they were followed. And certainly it's not a perfect study, but it certainly speaks to the tangible results that can be attained with a gem nurse if put in thoughtfully to support the entire emergency department.
Doug, I noticed you've got your hand up, maybe in response to that.
Yeah, I just, as a healthcare administrator, I think I turn this around. I'd say, listen, we know the biggest cost that we have now is loss of staff, right? Burnout of especially nursing staff and nursing staff who are leaving emergency departments, enormous cost to recruit them. So when you have a gem nurse, that increases the satisfaction of patient care. And I think that's the way to make the argument that investment really helps resilience of staff. So those are the kind of arguments that I would make. The challenge was saying it'll prevent admissions. There's always another admission to go in, right? So I think you have to make the argument it actually improves the environment in the emergency department. I think that's, especially now, that's a really sellable argument with any administrator.
And if I may add, we had one site who cut the gem nurse for a few weeks, but they realized quickly that it was not a good idea. So everybody was angry. Everybody wanted the gem nurse back. So they realized that it was an essential role in the emergency department and put her back with us.
Similarly, about 15 years ago, we started with one gem nurse with some sort of hesitation, worrying that it might not be the best for the department. That was going to slow things down, decrease flow. At the end of 1 year, the physician group actually took pay for results money that it had available to make sure that we had a second gem nurse because it made everything so much better. And Doug's point about recruitment and retention, I think folks at our site like working there better because some of those intractable problems that Nana mentioned are more easily addressed. But it isn't just gem nurses. I want to move on to somebody else. Osama, your talk was like this primer in quality improvement. Whom did you have to talk to get things started? Like how did you have to convince?
Thanks, Don. Yeah, I think there's two groups of people we had to convince. There was the folks that were actually working with this, but before that, you have to actually get the administration, the people that will actually make the decisions. Because as much as any initiative is good or any initiative will work or anything like that, if people are not told that this is something you have to do, they'll oftentimes just ignore it. So we basically identified the main decision maker at our institution, one of the VPs, and went to speak with them. And the big thing was, and this was advice that actually you gave me, Donna, is figure out what is important to them and speak to that. And at the time that we were speaking with them, it was all about overcrowding. That was the thing, right? So we made sure we came prepared with the numbers. Like Doug Sinclair had mentioned, we didn't just come in saying this is a big problem. We came in with a proposed solution. This is what we want. And it really was something, I think, where I wasn't telling them anything new. They obviously knew there was a problem, but they were really just waiting for a viable solution. So, we had done the work, we had worked with frontline workers, we had really fine-tuned it so it's something that could be successful. We thought could be successful. And with that, I think it was almost, when we spoke with them, it was almost like a relief. It was like, okay, yeah, great. Finally, there's something that we can do, kind of a thing. I was very, pleasantly surprised at. But ultimately, I think it's, you do have to start at the top before this goes on. Sometimes it can be difficult in a heavy bureaucracy like healthcare to figure out who is at the top sometimes, who actually pulls the strings. Thankfully, I've worked in the emerge long enough that we sort of know the ins and outs and that kind of thing, but that was it. And then the next step was, it's not enough just to have the VP tell you to do something. You actually have to go sell it to the people on the ground. And that takes time. Everybody is busy and they have other stuff to do.
Good. Thanks, Osama. We are coming around to time pretty soon. My last question is for Audrey. Audrey, you're the only site in all of Canada that has achieved this geriatric ED accreditation. Why do you think another hospital might be interested in doing it? What value does it bring?
Yeah, like I mentioned in my presentation, it really helped our committee to move on and to work towards a specific goal. So it was very motivating just inside of our group. And also we were able to convince the administration that we're doing change in the emergency department. It's good for patients, but also we're going to get this accreditation. So it's not really something really tangible, but it is in some ways to an administration as well. So the fact that we got it gave us a lot of credit. So now when we are asking for more stuff, for more resources, for more money, we have now credibility that we were able to achieve something. And when we present our project to our patient advisor, who's about 60 years old, she was like, are you going to put a sign in front of the emergency department? And we weren't really going to do it, but she said, and I said, why? And she said, but it means something. If I go to this emergency department and I see that it's accredited for geriatric patient, then I feel more confident in their care, and I'll feel more happy when I enter this emergency department. So there's a lot of good reason to do it.
Yeah. So I think it what you say recognizes the reality that whether you went into it for that reason or not, and whether you like it or not, we all work in a geriatric emergency department. And whether you make it a good geriatric emergency department or a not very good geriatric emergency department is up to you. And we hope that this position statement can give you some guidance to move there. So we are at time. Thanks very much for participating. We have a few last spots available in our Geri EM course on April 28th. If you're wanting to learn a little bit more. I would like to say a special thanks to all the presenters here tonight who took time away from babies and dogs and other duties that everybody has. And also to the members of the Geriatric EM Committee who really has put hours, tens of hours, hundreds of hours into producing this position statement. And to CAEP for supporting us in doing it and putting CAEP's position and authority behind improving care of older people. So with that, I'd like to say thank you to everyone and good night or good late afternoon.